Well, thank you everyone for coming today. This is the fourth Lincolnshire Coblator course. So we have done, no, this is the fifth one. Yeah, we have done 4 before. Today we have with us Liam Butler with the from Nephew. He will present it first, general presentations regarding to the concepts of Coblator. Later on, Mr. Salim will show us some of the implementations and procedures that we use the Coblator, and then we'll have the hands-on on the machine. We should have 2 of them, one of them in repair, sorry, so we'll be like squeeze a little bit around one. And we're gonna start now. We a bit late, but hopefully we're gonna run to the time. Yeah, Liam, can you?
Here's presentation management. All right, thanks a lot. So yeah, I'm Liam, Smith and Nephew ENT. I've been with Smith and Nephew about 8 years, pretty much doing coblation entirety. That's all we do pretty much in ENT, coblation and rapid rhino epistaxis packs. So just a quick show of hands so I can kind of gauge the room. Who already has some experience using coblation in their practice? Okay, a few of you. Okay, and where's everyone from today? From this area, region, and kind of, is it a mixture of trainees and middle grades and what's?
Can we
you can go around the room and trying to see how people are.
So can we just the middle grades, can they put their hands up?
Okay.
And the juniors, CTs.
Okay, thanks. It's just helpful for me to know, you know, as we go through. So I just want to spend the next kind of 45 minutes really just going over what coblation technology is, maybe debunk a few myths about the technology. We'll have a look at the evidence around tonsils in particular, because that's where the wealth of evidence is really. We'll talk a bit about the 2 different surgical techniques that have been adopted really largely for tonsillectomy, with extracapsular and intracapsular, and then we'll just finish by having a look at different sort of extended applications, but I'll leave that lastly really to Mr. Salim. We'll focus on tonsils with this really. So first of all, I just want to do a little so I can have a look in the room. How old do we think coblation generally is? Not just in ENT, but as a concept, as a technology. Do we think it's 15 years or 30 years? 30, yeah, correct. Okay, so how long has it been used in ENT for though? It's 1998. Okay, so it first came into orthopedics, and now we'll still see it to this day be used in sports medicine, arthroscopy procedures, things. It came into ENT about 1998, so it's been around a long time. Do we still think that it's a radio frequency technology? No? Okay. It actually is a radio frequency technology. Okay, so it is like your bipolar machines or any diaphragm machines you use, but it's just much lower in energy. So the voltages and the waveforms and the frequencies that are used within the blue box, we'll see later, are just much lower. Okay, so but it's still radio frequency. Like most radio frequency devices, coblation removes targeted tissue through a thermal process. Do you think that's true or false? Okay, it's actually false. So the key difference is, although it is a radio frequency technology, it's not a thermal process where you're essentially putting heat and energy directly into the tissue. You're putting it through a conductive medium such as saline, which creates a chemical reaction with a gas plasma bubble at the end of the wand. So it's actually a chemically driven process, which is why it's much lower temperatures. So the energy going into the tissue directly it's going into the saline, and that's where a lot of the heat and energy is dissipated through the saline. So it's a chemical driven process and not a heat driven one. I won't focus on this slide too much because sometimes it even confuses me a little bit, but essentially those that want to understand how it works is that the energy that is delivered to the tip of the wand goes to the 3 electrodes, which is 3 little wires at the tip of the wand. And you get your irrigation, which can be a conductive medium such as saline, which is what we use. And everything you see in green there, essentially the energy that is traveling through the saline excites all the molecules within it. And it's all those free radicals whizzing around and energy that is whizzing around within that plasma that does the breakdown of the tissue. So that's everything in green. Everything you see there in the purple is just byproducts. So when you see like that orange glow, that's not, an emission that's not heat, that's just the sodium being emitted from the saline. If you were to use some other conductive medium, it would glow a different color, for example. The vapor that sometimes seem it's just water vapor. It's just harmless. It's not surgical gases or smoke or anything to be concerned with. Can the coblation wands be used for sealing? Yes, they can, for hemostasis. When you're using it for hemostasis, think of it, those that have used it, you'll notice that you have to hold it for a bit longer than you would traditional bipolar because it's much lower energy, much lower temperatures. So typically with heat-driven processes, it may be 200, 300, 400 degrees. When you're using the coblation to remove tissue, it's typically within the range of 40 to 70 degrees, 40 to 70. We've done some recent testing, it was coming around about 62. When you're using the hemostasis, you're changing your technique, you're pushing the tip of the wand firmly onto the tissue with applying pressure and time. And when you're doing that, you're obviously putting more energy into the tissue, so the heat does rise a bit, to about 90 degrees. And that's why you have to hold it for that, second longer, really. So it's a long hold as opposed to a short hold that you're probably familiar with traditional bipolar. So you just have to hold it for that bit longer. But it's very effective. So I've spoke about the temperatures, 40 to 70 degrees. I answered that one for you. It's very precise because of the low temperatures and the gas plasma bubble. It's 1 to 200 microns. It's about the width of a human hair in terms of the precision of the plasma. The orange glow, I've spoke about that already. The orange glow is the tip of the wand. It's not because of heat. It's just the sodium being emitted. Those with experience in the room already with the coblation, and we'll go through this later in the setup. It's really important to get the balance correct between the suction and irrigation, because everything, like if you have too little irrigation, then it contributes to clogging. The electrical path is not connected because you have the active and return electrodes are both on the tip, and to complete the circuit you need the saline to connect the two. So it can cause incomplete electrical path, it can cause clogging. However, if you have too much saline, then the 3 little jets or the 3 little ports underneath the tip of the wand that you'll have a look at later, it can just shoot past the electrodes itself and miss the active electrode entirely. So, and then you're not completing the circuit that way. It can pull too much in the pharynx. But ultimately, what you're looking for in terms of irrigation is as much irrigation as you can have. You want it on a high flow, but you don't want it to be causing, too much pooling. You don't want to be necessarily working underwater, although some do. Doesn't matter, you can do, but you want to keep your visibility, and you don't want it too much that is shooting past the electrodes. You want it, nicely dripping over the tip of the wand. Equally, if your suction is too little, it can contribute to clogging. But if your suction is too high, if you do have you probably, you don't think, you see them sometimes in the NHS, but in the private hospitals as well, you'll see the like the Neptune Striker devices and suction machines. If your suction is too powerful, it can essentially suck in the irrigation too quickly, suck in the plasma too quickly, and it'll be ineffective. So it's really important to have that balance. So ultimately, we'll do it later, I won't focus on it too much now, you want a high irrigation and Normally, max suction is fine in most of the suction devices in the NHS. Have it on maximum, but just be mindful of that balance is critical to having a good experience with the coblation, for it to be effective and to not cause any blocking. We've talked about holding the wand longer for coagulation, 3 or 6 seconds. 6 seconds is way too long, but 3 seconds, if you actually count in your head, it's often longer than you think. It's quite a long hold. Probably don't even need to hold it that long, 1 or 2 seconds, but it's much quicker than the kind of spot coagging that you would normally do with bipolar. You can see the different effects on the tissue the longer you hold it. You don't need to know the settings for each wand offhand. Obviously, when you plug the wands in, the settings just come up on the machine, which is really handy. But depending on what technique you're doing, whether you're doing let's talk about tonsils, for example. If you're doing extracapsular, 7 and 3 is fine. You leave it on 7 as your ablation, and you leave the coag on 3. If you're doing intracapsular, you may want to put it up to 9 to get rid of, which is your highest setting for debulking, and to get rid of the main bulk of the tonsil on 9, and then you'll decrease down to 5. 5 is kind of your lowest setting for ablation. 5 is really the crossover between where the energy is so low that there's not enough energy to create plasma at the tip of the wand. So it becomes more of a resistive heating device. There's not much going on, and you'll probably get more likelihood of blocking and things like that. So on your learning curve, if you're new to coblation, and you're doing intracapsular tonsillectomy, we typically say, do 9, 7, 5, finish on the capsule. But once you've got a good level of experience, the anatomy well, you're comfortable with where the capsule is and how to use the device. Most are high volume experienced users, they'll start on 9 and probably some finish close to 9 or even finish on 7. There's no need to go lower than 7 really, but get familiar with the different settings and comfortable with the different rates of ablation that the different settings offer. 3 is no need to change the 3 for coag. 3 is sufficient for pretty much all bleeding, any bleeding that occurs. Ones can't be reused. Essentially, the stylets, so the engineering in the lumens are very thin. It's impossible at the moment to find a way to clean them, but we are being pushed more and more as an industry for more sustainable devices and reusable devices. So it's something that we're looking at improving in terms of our packaging and making things more sustainable and ethical. But at the moment, I don't think anytime soon they're going to be reusable. I've talked about how they work. If you have a look at the tip of the wand on the picture, you've got the active electrode, which is highlighted there with the 3 electrodes, and the return electrode set further back. And you basically need the irrigation to run between the two to connect the path. And that creates the gas plasma bubble. When you're using it, we'll go through it later, think of it like a paintbrush almost, very light touches on and off the tissue. If you leave the tip of the wand on the tissue too long, you just extinguish the gas plasma. It doesn't allow the tip to breathe and doesn't allow you to break down tissue. So you have to come on and off the tissue for allow the plasma to reform. So when you go back onto the tissue, it breaks down the molecular bonds and sucks it away. So you've got irrigation. So you've got suction, ablation, and coagulation all in one device. I'm talking about tonsils mainly, but Mr. Slim is going to talk about some of the other applications. You have turbinate ones, laryngeal ones. There's some other extended applications that it's used for, HTT, rhinophyma. There's many uses for coblation these days. I just want to highlight this as well, the terminology, because extracapsular tonsillectomy, think of it as your traditional dissection tonsillectomy, whether you use cold still, bipolar, coblation. It's a mixed bag of modes you can use for that technique. But really, I want to think about the difference between, obviously, what you're familiar with is a tonsillotomy or partial tonsillotomy compared to an intracapsular tonsillectomy. What we do in the UK is when we're doing an intracapsular tonsillectomy is we're aiming to remove as much tissue as we can, delineate all of that tonsil tissue back to 97, 98% tissue. What they do in some other Nordic, like say Sweden, some of the Nordic countries, they'll do what's more of a a partial tonsillotomy where they're removing 60-70% of the tissue, but they have high regrowth rates because of that. But it was brought about as a safety concern after they had some unfortunate never events. So it's just when you see when we're referring to intracapsular tonsillectomy, it's very much we're aiming in the UK and the US as well, and some other markets. It's aiming to remove all of the tissue, whereas partial or tonsillotomy is very much as you suspect, moving some of the tissue, 50 to 80%. This was an interesting slide that always get our faculty when we do our courses in London. Always refer to this slide. It's just a slice of tonsil where you can see the plane in the upper aspect is the tonsil. You can see all the arteries and veins in the muscle at the bottom of the picture, and they pretty much double in size as they go through the muscle, through the constrictor muscle into the tonsil, and that results in about 16 times more blood flow, which is a far greater risk of bleeding. So, which is why, particularly in pediatrics, there's been a big transition to intracapsular to stay within that plane, to minimise any chance of any post-op hemorrhages and bleeding. I'm sure you've probably all seen what an intracapsular tonsillectomy looks like. This is Nico Jonas, a pediatric consultant at Adam Brooks. It's been doing them for many years. But you'll see this, essentially it's just a dabbing technique. You can do longer strokes, short strokes. The key is to keep the tip of the wand moving. Have your irrigation high. You can see the irrigation is pooling a little bit in the pharynx. That's fine. Every now and then he'll just put the wand in, suck that up. It's using micro-cuffed tube. Some people, if you've got the coordination with your anaesthetist, you can use LMAs, works fine. There's enough space. And he'll just keep going like that until you reach the capsule. But it's very much listening, keeping your ear to the suction. If you feel like it's compromising, so take the wand out. We'll go through it later, what you need to do to unblock the wand if it does block. But you'll find in your first sort of dozen cases, you might have 1 or 2 blockages. After that, once your technique is good and you learn to manage the tip of the wand, you'll find you'll never, our high volume users, they never ever block the wands, because they know how to use it effectively without blocking. So when you get to the capsule, what you're looking for some key indicators. There's a sort of a color change. There'll be a brownish tinge. It'll become more fibrotic, the tissue. When the electrodes gets close to the sort of anterior and posterior pillars and the muscle, you'll see it start to twitch. So it's a good indicator you're close to the capsule itself. And it's just experience. The more you do, you get to identify what the capsule looks like, and you'll delineate as more tonsil tissue as you go. Some people say as well, when you're using coag, if you're on the capsule with coag, if there's still tonsil left, it will kind of bubble and there'll be some fluid there. But once you coagging and it's pretty dry and there's no bubbling, that's a good indicator that you're at the muscle. There's no tonsil tissue left. It's always a difficult one to answer, but essentially it's an experience thing as well. We'll go on to the next slide. How do I? So, okay, extracapsular. I'm sure you've seen 1,000 of these already, but with coblation, the important thing should play. I'm just going to wheel it on.
The following video for the tonsil using the ablation function in order to identify the tonsil capsule.
Not playing.
Orient the wand tip medially to create a finer dissection and avoid injury.
Okay, I'm just going to talk you through it, and I think perhaps Ms. Slim's got a video later anyway. But essentially, with extracapsular tonsillectomy, the key is the technique is obviously you're retracting the tonsil and finding the plane as you normally would, but you're keeping the tip of the wand facing medially as much as possible, away from the muscle, and you're using the bottom leading edge of the tonsil to do that. We'll touch on more about surgical technique later. We can have a chat in the next presentation, and we can have a chat when we do the practical about technique and things like that. But that's just a general basis. Before I move on to the evidence, are there any questions about either the technology of the the coblation itself, how it works, or any of the techniques. Yep.
It's still not clear, like how the technology gets rid of the tissue. Does it vaporize it? I know you've said that plasma gets rid of the tissue. How exactly does it do that?
Yeah, good question. I'll try my best to answer. But essentially, how it's described to us is it creates basically it creates enough energy to break the molecular bonds of the tissue, and it just basically dissolves it away and vaporizes it and sucks it away. At a more granular level, I mean, that's maybe more of a basic answer than you're looking for, but that's how it's described to us. But yeah, it's just a low form of energy essentially that when it comes into contact with tissue, it dissociates the molecular bonds at that level, and then it will just vaporize and melt and kind of get sucked away with the suction. Same with you using the so when you're using the coag and you're putting the energy onto the bleeding or onto the blood vessel, it basically just oscillates and vibrates very quickly that blood vessel, so it shrinks and closes and seals the vessel. There's two different ways of it working. So you're using the coag, you're using the energy straight onto the tissue to seal and oscillate the vessels and get them to close. But when you're using the ablation, it's very much a lighter touch. You're letting the plasma do the work to break the molecular bonds and suck it away. Yeah, that's the best I can answer, I'm afraid.
Thank you.
Any other questions? Yep.
Is it really this same question, but in another way? Is it really change the tissue to another material, which is the plasma, things that, to another kind of a tissue or material that we suck it out? So does that mean that if we are doing papillomatosis, we still need to wear the FPP or we wear the regular mask?
Yeah, I don't think there was a because obviously a lot on
using laser example, we had to use the FPP.
Yeah, so around COVID, obviously it was a big thing, and we have got a like a paper that was put out to say that there was no, it doesn't affect, there's no airborne particles or risk of any airborne materials as much as we could test that that come from the plasma or when you're doing the papillomas or for tonsils. So I mean, it was something that was raised obviously around the time of COVID because of the airborne stuff and the need for masks, but everyone was obviously just super cautious and wore the masks anyway. But yeah, it's not something that millions of these have been done now, and there's nothing that's ever sort of come back. It doesn't create any other material or reaction that I'm aware of that we know about that can cause harm in any way. Like I said, the only thing that is created is sometimes that gas plasma, the kind of smoke, but that is just the water and the water vapor and oxygen, hydrogen reforming and causing a bit of smoke. But yeah, there's no real known concerns about that. I'll move on to the evidence because there's a bit of evidence, and I'm not sure how much time I've got left. And then we'll go over there. So there's masses of evidence now for coblation tonsils, intracapsular techniques. It's about 7 or 8 years ago that it was kind of what started to be adopted in the UK. So much that in terms of children's tonsils, about 50% of tonsils are now done with coblation, and about 45% of that 50%, most of that is intracapsular. About 5 to 10% is extracapsular. All the high volume tertiary centres now, they've standardised with intracapsular techniques with coblation for both obstructive indications and recurrent tonsillitis as well. This paper here, it's last from 2021. There's actually a recent update that we've just kind of bringing together now. It has been published if you want to have a look, which is 3 years on from this paper. We're at about 1,800 or 2,000 cases now, but this is a prospective study of 1,257 cases at the Evelina in London, big tertiary centre. looking at coblation intracapsular with long-term follow-up. The follow-up period was 3.9 years at this point. We're about 7 years now. Obviously, they're doing a lot of young kids in a centre like this, so it's a lot of them have OSA. The mean age about 4.2 years, but they did obviously go up to 18 in the patient group. It's over 7 years. You can see a lot of OSA, 58%, a lot with OSA and recurrent tonsillitis, where I imagine, I'm not sure whether the OSA or the recurrent tonsillitis was the primary indication, but they certainly had a mix of both in that group of 37%, and then recurrent tonsillitis of only 5% as the main indication. No primary bleeds at all. Post-op rate, complication rate of about 0.5% as a secondary bleed rate, which is still in line now. We say less than 1% typically. No returns to theatre, no readmissions with any pain. Return to normal diet quicker. It's saying medium duration of analgesia is 6 days. Medium time to return to nursery is about 7 days. They use the T14 scoring system, which I think is on an ENT UK way of collecting the data. The revision rate, which is something that gets brought up, is 2.6%. You can see most of those, 24 out of the 33 of revisions were for obstructive symptoms again, and 9 were revisions for recurrent tonsillitis or sore throat, where they just used the bipolar the second time around. Medium interval was 2 years when they needed the next surgery. You'll see the point at the bottom. This is very key, and we've got some data later that we'll share with you that shows the difference. Most of this revision rate, most of them that are coming back were either 3 years or under. So it's largely in that group where they've got more active lymphoid tissue. They seem to have a higher revision rate. If you take the 3 years and under out, then it's less than 1%. It's much lower. But you can see most of them are OSA. So breaking it up even further, you can see in OSA only, it was 3.3%. OSA with the recurrent tonsillitis group, 1.9%. None with the recurrent tonsillitis. Second paper, and this was Sam Kamani, was involved in this at the East Surrey Hospital. Just looked at a patient group of 80 children undergoing the CIT technique. Mean age of 7.2 years, because it is a different, it's not a tertiary centre, so you've got some older kids in there, which is good. So it's looking at a different mix. But it was looking only at infective indications. Recurrent tonsillitis alone, some had a mixture of current tonsillitis and sleep disorder breathing, but it was recurrent tonsillitis was always the primary indication. And that was a 13-month follow-up, and none have come back within that 13 months. Obviously, it's only 13 months, but it's a good indicator that it's safe and effective for that patient group as well.
What were their bleed rates, sorry?
The bleed rates, I don't think it had any readmissions. Yeah, no primary or secondary readmissions within that 13-month period. I mean, if you want to call it a flaw, the thing is, it's only 13 months. But yeah, it's initial really good results looking at just recurrent tonsillitis, 80 kids.
But it was from one centre only, and do we know the level of the surgeons as well? Because coblation is done by the senior surgeons. So
yeah,
the practice will move on.
This was not just Sam. This is him and his registrar predominantly did a lot of them, is my understanding. Yeah.
Okay. Right.
The Getting It Right First Time publication in 2019 had some good data in it, and some good recommendations for the technique. In 2019, for pediatrics, the bleed rate across all techniques in children's 5.7. You can see it's even higher in adults. I think it's like something like 12% in adults, I think, but it's not on this slide. But yeah, so 5.7% across all techniques in children. You can see here, this is on the outlier Evelina with their early data, and back in 2019, so one of the first to kind of standardize and adopt this technique. One of the targets is to increase day case, which obviously with faster recovery times with intracapsular techniques it enables you to increase your day case rate to a target of, I think 80% is the target. So a lot of people have high day case rates, not everyone, for tonsillectomy. I mean, it was always 6 hours post-op. Now the girth recommendation is 3 hours if you're doing intracapsular, and some centres have even trialed 2 hours. But typically 3 or 4 hours is typical now to stay post-op with intracapsular. Some of the recommendations here we've highlighted in the report. So you should consider coblation intracapsular as exceptionally low rates of complication in regards to postoperative recovery. Wider adoption of coblation may increase day case rates, and that's one of their targets by reducing overnight stays. This is a paper, a meta-analysis that was put together by Stephen Powell in up in the northeast, and it basically involved 4 tertiary centres that we know do exclusively intracapsular coblation. So I believe it was Newcastle, Addenbrooke's, Evelina, and Manchester. The total procedures was just about 5,500. It's across, obviously, to your point earlier, the entire, it's using hospital episode data, so it's the entire hospital statistics across all surgeons doing the procedure. So you've got a real mix of different levels of experience, and consultants and juniors and trainees doing the technique, and it came out at 1.2% were in terms of readmissions for bleeding. You can see 0.3 is very low with pain, some other bits in there, but the key thing is what I've highlighted at the bottom is it's got 5 years follow-up, so it's 2.2% at 5 years in terms of a revision rate. So that kind of goes aligns to the Evelina series that we were looking at, which I think was 2.6%. So I think typically when you're consenting, and obviously this is inclusive of all indications, OSA and infective tonsils, you can typically quote a much safer procedure in terms of bleeding. You're going from maybe 5-6% as an average to less than or around 1%, less than 1% bleeding, much less pain as well. But the trade-off is that they may need another procedure, but it will be planned, they'll know about it, and it's between 2 and 3%. So there's no returns to theatre with this technique that we're aware of or in the data. So it's really, whereas with traditional tonsillectomy, it's somewhere between 0 and 1%. So it's really when you're consenting how a lot of our experienced users will consent. They'll say, look, I'd like to do an intracapsular tonsillectomy. It's much safer in terms of risk of any bleeding. It's much less painful. You'll be back to school quicker, parents back to work quicker. However, there is a 2 to 3% chance you'll need another procedure, but you'll know about it, it'll be planned, and it won't, it's that versus a 2 or 3 or 5% chance of coming back with a panic and an emergency bleed or being rushed into, an A&E with a bleed. So the parents will always, if you consent in that way and explain it in that way, 99 times out of 100, they'll go with the intracapsular. Some centres just don't give them the, that's all they do. Some will still consent and give them the choice. So it's up to you. And then lastly, this was a big systematic literature review looking at the 2 techniques really, total tonsillectomy versus, or extracapsular total tonsillectomy, whatever you want to call it, versus intracapsular. So you've got just over 4,500 total tonsillectomies versus 2,000, or just under 2,000 intracapsular. There were 17 papers included. 15 of them were predominantly kids, so 2 of them were just adults and kids, so mostly pediatrics, couple of kids, couple of adults. There's a variety of techniques in there, obviously, that you've used. You've got coblation with 9 studies, but you've got different techniques which will typically be used for the total tonsillectomy. includes obstructive and infective indications. And what it found is that looking at all of this data, this is a level 1 piece of evidence as well, so it doesn't really get any better than this. They found what was statistically significant in terms of the diamond and the line of effect, if you're familiar with that, and the N values, is that kids would typically get back to school about 4 days sooner, and they'd come off any analgesia 4 days sooner as well. Return to normal activity 2.8 days faster, return to normal diet 3.5 days faster. And in terms of the bleeding, it was also statistically significant that it was a much reduced risk of any bleeding occurring. But there wasn't enough data to compare a significant difference in total post-tonsillectomy hemorrhage rates by going back to theatre, because there just isn't enough enough of that data being captured or incidents in the papers to draw that conclusion. So in terms of comparing the two techniques, is it statistically significant in terms of improved bleeding? Yes. That pain? Yes. Analgesia? Yes. Activity? Yes. The risk of needing a secondary surgery in terms of revision, this is what normally will come up. There's not enough sufficient papers at the moment reported on in the meta-analysis and the follow-up periods were too short to sort of draw a conclusion to that. But you have got the previous papers that I mentioned, which are about 5,000-6,000, patients, the other's 1,000 patients, where it's between about 2 and 3%. So you can quote that. There's some good numbers, some good papers. That's it from me, really. I'm not sure how long. I'm sorry if I overrun, but we're also doing this course today, but we've got other courses, so you can always get in touch with me. And if you or your colleagues want to come on any other courses, we have courses all over the country, really. Our main education centre is in Watford, outside London. We have other courses that we run, and it's really helpful when you guys. So thank you to both of you for supporting the course here today, because it does help. Any questions at all around anything I've spoke about? Yep.
Just one, do you have any separate evidence for doing coblation in adenoids?
To be honest, there isn't any papers that I've seen that's specific to adenoids. Adenoids is a real, I'd be interested to know what to do, because adenoids, if you're using, everyone that uses the coblation for tonsils.
Is there much evidence on bleed rates for extracapsular tonsillectomy with coblation?
Yeah, there's loads of papers out there for extracapsular. Okay, so in 2017, coblation was used for tonsillectomy about 11% procedures. It's now up to 50%, and that's because of extracapsular. Back in 2017 and before, obviously the previous 15 years of coblation, everyone would use all sorts of different modes, modalities, and there'd be lots of papers comparing the different techniques, whether it was bipolar scissors or steel and ties or bipolar or diaphragm, whatever you use. There was loads of comparisons, and there would be some. It's a real mixed bag. You'll get some that say coblation's better, some that say coblation's worse. You've got the tonsillectomy audit in 2006 or 2007, which came out as cold steel being favourable and coblation not being so favourable. That was,
I mean, the reason I ask is anecdotally, I mean, those figures look really good, but in training, I worked at a centre where they did extracapsular coblation tonsillectomy, and anecdotally, I would find that the patients would, at a higher rate, return after about 10 days with a very small bleed that needed nothing doing but conservative management. And I audited it, and it was slightly higher than the, standard cold steel or bipolar.
Yeah. I completely agree with you, but part of the problem is training.
Yeah, that's what I'm saying.
The key point in the coblation. I
Actually,
remember when I started with Mr. Ibrahim, when we were doing fellowship in Ireland, we had a really high rate consultant and registrar level
of that small bleed.
Yeah, however, technically, with the time going on, I can say for the last year, I have done more than 50. I had only one case come back.
Yeah, it is like anything, you only get really skilled at using one instrument, you're gonna have good better outcomes than the average.
Yeah, the same what Mr. Sam was saying. When you start, the problem is that you used to have like an eyesight inside the tonsils. Where's the capsule? Where's the muscle? When you use the coplator, the problem is that where is it? Am I enough in or enough out? This is the point. And I find it myself is just to irrigate a lot. And sometimes I use the patties as well, the tonsil patties, and just to clean and wipe with the tissues. Just, oh, yeah, no, still I'm not away from the. So sometimes if you plan to go for intracapsular, you find yourself it's just you pass the capsule when you start, or the other way when you started the the extracapsular, you find yourself is taking much from the muscle. So if you're using it's like when you do the intracapsular, you're doing it mainly from like a scrapping thing inside outside. But you'd be surprised that if you do the extracapsular, I don't know, Mr. Simon will show you some videos. You do it the other way, so you can turn the ones to the other way and just go between the tonsils and maybe because it will vaporize the tissue anyway. So you vaporize the capsules more and separate the tonsils. Like you're taking from the tonsils from the back and push the muscles away. So, and depend on how much you've done. Yeah, I agree. And by the way, the chance of bleeding is there. Thanks, man. So we are running out of time as well. So we have a presentation with Mr. Salam. We're going to set up the collator. We also would like you to join us in after this course. We have a small presentation and a bit of I think this is again a training as well for Vox. We can call him here. Yeah, no, we have this lecture for the whole day, so it's not big issues. We don't need to move around. So we're gonna set it up. Hopefully everyone will have a chance to put up hands on. Mr. Salam will talk about the his points regarding to the technical and the indications as well.
Thank you for coming today. I have to squeeze myself as I can, just give you a little bit of time to just hand over the things to each others. So I'm fanning of coblation really, which pushed me to get my daughter having adult tonsillectomy through coblation. I think the main problem of the before coblation was facing the ENT surgery is the pain, the post-operative pain. This is a really challengeable point, which facing most of the patient post-operatively. For the question who was asking about the coblation, my understanding is the coblation is a controlled ablation, try to release the intracellular bonds. When you release it by plasma-free field, you can suck out and destroy the cell membrane. From this point, the population has taken the upper hands compared to monopolar and bipolar. It has low temperature. It minimizes the tissue damage by delivering a cooling system through the saline. Yeah, compared to the bipolar, which can reach up to 400 to 700. So the era of using the coblation has been moved. I think I was lucky when I started the first training in 2015 on the coblation, when we started to do adenylidectomy and tonsillectomy, where we got a very high rate of post-operative bleeding. I have been auditing the intracapsular when I was in Limerick, and we found that most of the cases came back was due to missing the superior pool of the tonsils, which usually hidden from the vision. To which what we decide to do in this audit is to release the angle to get the intra upper pool tissue. Yeah. Then it had been moved to the turbinates and then the laryngeal surgery. I use it frequently when I get an supraglottic airway obstruction. It's really safe to use it in the tumors with a minimal invasion to the tissues and less rate of the bleeding. If you use a laser, it is causing thermal damage. If you use a macrodebridor, you get post-operative easy swollen tissue, which can lead to end by tracheostomy. Yeah, there is two techniques has been described for tonsillectomy. Simply, we can say with either we are medial or lateral to the tonsil capsule. And the idea of the intracapsular tonsillectomy has been raised up for the kids rather than 3 years of age, when others were using the microdebridor. I have seen this by my eyes that techniques, they use a microdebridor, especially in obstructive sleep apnea. However, the post-operative rate was horrendously high. And then the era of the population come and replace it with a less minimal bleeding. If you look to this video, I just got a snap of those videos just to, if you see the idea of the coblator, it's just you bend the tissue, okay? The more you touch the focus of the tissue, the more the ability to go and create a hole with a high tendency of bleeding. I wouldn't, if you look to the device here, I would say listen to the device, don't look to your pedals. There is a yellow pedal and there is a blue pedal. Please listen to the sounds rather than, because intraoperatively you're just focusing on the mouse. You're not, you just need to listen to what is going on. You have to train yourself with what pathway are you using? Is it ablation or coagulation? Yeah. So if you look here, he's painting. My understanding is once you reach the capsule, the muscles start to contract. Okay. And the colors start to change. Yes, this is from Sam Khomeini. He's one of my colleagues. I worked with him in London. He's a really nice guy. Okay. And if you look here, he's just focusing on, sorry, if you saw, he's just focusing on the superior pool, which is a common site of post-operative bleeding. Oh, actually, I say infection followed by bleeding. Okay. Sorry for the timing. Okay. For the extracapsular, I personally use it for most of my endoscopic band endoscopy and tonsillectomy as a biopsy. It's less painful. You see the patient is just smiling in the recovery, say it's fine. Compared if you use a monopolar, it is traumatic to the tissues. I have got patients admitted a couple times of recurrent bleeds due to using. So the idea here is to get the handle away from the tissue behind and to move in the space between the capsule and the muscle. Yeah. I personally see once you reach one of the blood vessels, what you need is to put your feet or your pedal on coagulation for a couple, like 2 to 3 seconds. See, this is the bladder. Most likely, this is the consular vein. Okay. And you have to retract all the time the tonsil medially, so you're not reaching the muscles. Any questions?
Just in terms of direction that you're pointing the wand in, I think in the first lecture, is it Liam mentioned angling the wand medially, as in the tip of the wand medially. But on that left-hand video, the tip of the wand was angled laterally.
I wouldn't say angled laterally. I would say face the tonsil and walk on the capsule out and in, out and in.
For intracapsular, you have it face on.
But in the, yeah.
For extracapsular, you
Makes it
medially as much as
Okay.
okay. Because you can easy preaching the muscles.
Yeah.
If you find a very embedded or buried tonsil, is like extracapsular a better option?
Definitely, I agree with you. I would say for adults, I use extracapsulars. Yeah, because the adults has a very hard tonsils.
So you recommend the intracapsular?
Sorry, I missed your question.
You recommend the intracapsular concept?
I will say intracapsular for kids. I'll say extracapsular for adults. Yeah, because usually when you use the coblator for adults, it's my personal experience, it's very hard to take it out. You know what I mean? They have a lot of tonsillar, scarring tissues, a lot of stones inside. Sometimes it's very difficult to reach that. And you leave a remnant, and those people will come back and back by bleeding, by infection, sore throats. Yeah. Sorry.
I think the head point for intracapsular is in here. We are talking about something different than 16. Right? I'm not talking about intracapsular. About 16, I'm not talking about intracapsular. If I'm right.
Yeah, I use it in children. If like the child get a febrile convulsion, I have been using it in those children who can be referred to us by, like let's say simply by pediatric team says you get a febrile convulsion. I'll take it extracapsular, even if it's child. Yeah, so don't leave any remnants behind me. Make it sure. Yeah. Okay, this is advice. I'm not fanning by this technique actually. I'm sorry, my microscope doesn't record. To using a mirror to look at the post nasal space. try to find, I use a camera, okay? I use a telescope, either pediatric or an adult, to take off the adenoids, make sure I get a flat. Yeah, one of the challengeable is the adenoids. There is not a lot of studies about using coblation in adenoidectomy, unfortunately. This is one of the limitations of the coblation at the moment. Yeah, because I don't like to work blindly. I have a camera, I can use it simply.
You use an endoscope from the mouse 120 or?
No, I use it through the nose, put the patient in, yeah, straightforward, and I go for it. And I put a patient, his head little bit up so I can suck the water straight forward. Yeah.
Is your coblation one going through the mouth still?
Yeah, coblation, just post tonsillectomy, just like tonsillectomy positioning, but I get to catheters, get the soft palate up and go from the mouth and through the nose.
Yeah.
Okay. And you can see he just keep ablate the adenoids. And if you look to the end of the video, he starts to do an hemostasis. Yeah, which is one of the very challengeable things in adenoidectomy. The more you traumatize the adenoid, the more it does bleed, because you're just breaching very easy postpharyngeal wall, the posterior pharyngeal wall. Yeah. This video came from my colleague, Mr. Abrahman, using coblation for recurrent respiratory papillomatosis. Okay, it has been used. Anybody knows what the recurrent respiratory papillomatosis? Any ideas? What's the recurrent respiratory papillomatosis? Any ideas? Yeah, it's a viral infection causing by human papillomavirus 6 and 11. Okay, 2% of the staff has an incidence or has a risk to get infections. We don't know how does it transfer. We say from mom, from dad, from what, blah blah. Nobody knows. Anybody of the staff can catch it up. The good, I think, in the coblator using in it, it has a continuous suction through a water, so you don't get any evaporation of viral particles outside. It's not established, it's not been discussed before, but this is my impression about it. However, I still insist to use ideal masks for HPV intraoperatively. Yeah. So I think you were asking about recent study. There is a study came recently, a Cochrane review about using intracapsular tonsillectomy in the NHS in England, showed a significant and dramatic drop in the number of primary and secondary bleeding rate and the tendency back to the emergency compared to the previous national audit, which was done in 2005. And I believe this is because of the training has been done much better than before. Yes. It can be also used in HHT. Anybody knows what HHT is? Hereditary hemorrhagic telangiectasia. It's a genetic disorder where patient can develop avascular lesions in the nose with a high tendency to bleed, not easy to be controlled. I have been trained with Prof. Khalil in Plymouth and my rhinology fellowship about it, and we found that compared to the CT2 laser, there is a dramatic improvement in the outcome of the nose due to the less thermal effect and also less chance of septal perforation compared to the CO2 or KTV lasers. I think the future challenge is the cost, but it is possible. It needs a little bit of training. If you look to online, there is not a lot of studies about it. Just everything is focusing in tonsillectomy only, whether it's tonsillotomy, just to be medial to the capsule, or lateral, which is the extracapsular type. Yeah, I think this is a limitation, and the size. I feel sometimes very difficult to get the handle through the nose. Thank you. Any questions? Thank you. We have a lot of strawberries. The chicken, guys, is not to eat it, just to order it.
Yeah. There is first. So I would say if we find ourselves one over the session, one will stay here. Change around. That's okay. So
Yeah.
1 second, 1 second, chat. 1 second. Okay, we're gonna show you how to set it properly and we set up, show everything, and then the Stalin will go to the demonstration that we ablation and coagulation, and then you will have hands on the strawberry, first the meat, and then the strawberry, and then the.
Yeah, so this is okay, I'll wait till we just.
A&E is the water.
Do you have it, you will 100 points, do you have it? Sorry, we need 100, we need 100.
Never won, yeah, we can get.
Please, sir.
That one.
Stop now, yeah?
One is go through the setup.
Yeah.
Because I think it's really important. And we'll do a bit of a practical picture. So the setup is really easy. But it's just literally those three things that are always the same thing that go wrong and like it's about. So if you can just remember those one or two things that I showed, at least if you're, theatre staff or team change, what's going wrong, you can just check it out because that's what's wrong. System itself is really simple. You've just got obviously the console, the foot pedal, and this grey box, which is just controlling the flow of the sailing. When you switch it on, it should come up with 0 and 0. 9 times out of 10, you'll find the foot pedal is already plugged in. It can only go in one location anyway, so you can't get it wrong. Then you've got a cable here, this grey cable that controls this switch here, powers. And again, there's only one spot at the back. The connector is the same both ends. You can't get it the wrong way around. 9 times out of 10, when you come into theatre, it'll already be like that anyway, be left like that. So the only thing that you need to then do is plug in the wand. And this is obviously what will be set up for you. There is something I just want to show you because typically this is what goes down. The tonsil wand, we're going to when you open the tonsil wand, there's essentially 3 things you need to do. First, suction, the electrical component, the irrigation. So the electrical component, dark grey wire, plugs in the only hole. For example, is not 73. She can make it 73 optional capsular, as we spoke about earlier, change out. So if you want to start capsular, then got your suction. So with this suction, it is really important just to have it on one line. Don't share it on 2 lines, split it in half or anything, because you do want maximum suction. I spoke about earlier about the importance of balance between the suction and the irrigation. So make sure it is on its own line, don't split it. Have the other Yankee sucker nearby, that's fine. But if you need the Yankee sucker, just get the scrubbing point to swap it on a single line. Don't have a separate line. Split it. And then the last thing, this is the thing I want to show you. So far, it's super simple. I'm sure you agree. It's easy to set up. We're gonna set up the beginning set. Now, this is the bit that they'll get wrong sometimes. Experience because they don't put the tubing in here correctly. Saline just carries on pouring all over the drains. You'll put a knot on the foot pedal. You'll say, why is it pouring everywhere? It's because it's not here properly. So I just want to show you how to do this bit. You can at least say it's flowing everywhere. You put a knot on the foot pedal. Say, can you check this box? This is what would be the problem. I think about saying. So Sailing will always be at least 3 foot. It's a gravity fed system, not a pump or anything, so it needs to be as high as possible, really. The sailing trips down at least 3 foot above the patient's head. Where you're going to control the flow of saline from, now you can leave this up here if you wish. Some people do, or you can roll it all the way down to whoever's scrubbing, them to control it, or for you to control it if you want. I'll leave it up here for now. But the first thing I do is close it off completely to avoid saline going where it trips. By the bag and leave it about half full because you want to be able to look at this to set your flow rate. Don't look at the tip of the wand, and I'll show you why in a second. Always look up here. Now, the last thing, this is the thing I've been getting to that you need to remember, and this is what they miss up. So this is just basically, this switch here is just a pinch valve that goes backwards and forwards. I turn it to the side, you can see how it just goes backwards and forwards there. Yeah. See backwards and forwards. So you want the light on, which means valve open, to be able to put the tubing in. What they'll do 9 times out of 10, they'll come along, they'll put it in like that, they'll put the switch down, they'll say, yeah, it's ready, it's good to go, and then saline will just carry on pouring. Because if you come around, what they've done is they've put the tubing in, but it's sitting around the circumference of the silver plate rather than on top of it. So you need to tug it right in, so it's sitting on top of the plate. So imagine like a clock face. Basically, that wraps the tubing around the circumference of the clock face rather than the front of the clock face, 6 to 12, where the pin then comes in and pinches the tubing. Essentially, saling's running everywhere. Get to check this. Make sure they've tugged the tubing right in so it's sitting on top of the silver plate. That's number one thing they do wrong sometimes. Second thing is they'll put the tubing in, and it might be in the correct place. Then they won't flick it down to auto because they think light on means it's ready to go. It doesn't. Light on means valve open. So you put it down to auto, and then if you put your foot on the foot pedal, if one of you wants to demonstrate, the light will come on, the valve will open, saline will flow. So the two things you need to check, then prime it, we'll open it up for me. You need to open it up like that, or you can put your foot on the foot pedal. We'll open it up. Once saline comes at the end, it's on its way. Put the switch down. So just to reaffirm, two things in here. The saline is flowing everywhere. Make sure the tubing is sitting on the silver plate correctly, and that the switch is down to auto. The light is off to start with. When you feel the pedal, the light comes on, and valve opens.
So when you prime it, it be on auto, or do you have to take it back?
So to prime it, if you think you want to open the rollable fully to speed, you can, and you basically want to open the valves. You can either do that by just flicking it up here,
Yeah.
or
Or
the
pressing
or
the two options.
Two options, yeah. Two options for you. A lot of people just try the film. But then the last thing to do is set your flow rates. Now this is the other really important thing in terms of balance and correctness. So if I hold the wand here, right? So if one of you wants to put your foot on the pedal, you see it just steams quite a lot. Hold it this way, drips a lot more. Hold it this way, it steams. Hold it that way, it doesn't drip very much at all. Don't use the tip as an indicator of what your saline should be. Always look at this here. So if you put your foot on the pedal again, just be a continuous stream of saline. Put your foot on the pedal. That's too much. You just keep reducing it. It's like a fast drip like that. Okay, so you want 2 or 3 drips a second. Don't look at the tip and think, try and guess how much saline. Depends how you hold it. Always look up. So when it comes to surgery, you're going to be holding it very much like that. Drip just as you want to. But it might use this as your gauge, not the tip. That's it in terms of setup. So that's really important. The irrigation balance, this box. Remember those two things, then you're set up. We'll be good to go to have what I'll hand over to you.
Okay, thank you. Guys, I just go through what I do, okay? Simply, just to make it easy for everybody to try it, yeah? So listen to the sounds, you know what I mean? You can let yourself get with the sounds, yeah? See, as Liam mentioned, you know, look here, see what I'm doing. So imagine the tonsil, this is a child tonsil, yeah? What I'm doing here, I'm painting. It's something. It's actually something. Okay. Keep going. It's your cross dialysis. My reason to play, how you do it. I thought on the dealer point, you see the roughly. You can see that the making is efficient outside the How you can see that especially if you use it to learn it. If you can avoid damage of the whole stop the pattern. As an egg. It's really so you need to leave. That's why send them against, when they're off the running, which really is. I don't know. Yeah. Okay. The idea is just to keep it like that. You all know. It's staged without doing it. However, the other concepts is exactly like the beat here. See how much is stronger here. You need to be a little bit slow works. You see, you come towards the throat, yeah, and then you can continue it, like, but still, I can suck it out. If you get your blended blow, so you don't get a syringe. If this one, yeah, get a syringe on, like in manually, something else, you get it done. You know me, like the microwave writers, okay?
Yeah.
This is a top, very top tissue, yeah? And then again, the pulses, similar like that. It's capsular, intercapsular, it's intercapsular. What is you said about the product, okay? You made, if you look at, you can imagine this pulse factor. Where is the area space? The typical area, including the area, right? It's beautiful. You can from just get the scopic view from above. Which one is missing? Yeah, you're missing this bit. Okay. That's the yeah. What I do personally, I just film myself like that with an iPad. I do. It's hard to see it here. You see, completely just okay. Finally, the noise. I don't like this mirror technique. I hate it because if people apply decision tree, it's a big problem. And I had one of my patients and previously suction my thing here. And then she goes to the small time. You look at this decision tree, it's not, you can see the office. So I would prefer use transfer on and it's not like it through zones. Yeah. So you look away from the cross position like that. Yeah. What his feet a little bit down, then the head up, so you can suckle with your seat forward. You know me? I would, you know, I would say I use it prescriptively, but sometimes if I get infected tonsils or infected adenoid tissue, what I do, I put the egg. Okay, leaves. Egg. Leave. Am I right? If it's bleeding groundlessly, like infected,
It's bleeding a lot, yeah.
Yeah, so I use coag.
Yeah.
So 1 to 2 coag. Low. Okay.
Adenoid coag gets not 3. Well, adenoid coag gets 1 to 2, not 3. So tonsil, it's 738.
It's 7-3, Bradwell, I think on 7-3.
7-3, I would prefer, what I do, this is a really nice question, really. It's a really good question. If I have a really large adenoid, large tonsil, I go a setup.
Yeah.
So just that morning. Okay. Let's say the tonsil size is like that. Okay. I speed up, then I come near, and then I go back. Okay. It's different. But you need to be bit. I wouldn't say, I wouldn't recommend software, but so I take very, very fast part of the gland. Okay. Sorry, part of the tonsil. Okay. And then when I come breathe, I reach the point, so there is only enough smile. Smile at the back.
Carry on.
On here. Like faster pathways. Then when I reach like 70%, I go back. 1, 2, 3, 4, 5, 6, 7. Okay. Right. I think Mr. Ahmed can go through the video both seats. We need to switch the yeah, when the first measurement is ions as a fish, right, the application of pain.
Yeah.
Well, yeah, the doctors then the mean, which is really important to you know, and all 5 of the parents also. And on the mean, which is you get that but we think to them. Yeah. Yes. Yes.
September 1. Yeah.
The indication can interpret the normal blood exercise. You are doing a house structure well. And so this is our practice. I'm showing you on the now structure that I really do this. And it's a really this is normally what is the indication region which will be the allergic crime and not medical treatment in this size. I will contact criminal so these slides are not The side, but then I mean, this can give them 6 to 3 years, 6 to 2 years. That's. But in my long lost research and different way, somebody can review block your mic, because you know, as a topic to remove the remove this issue and fact, I think this is a little bit more better than the other in my mind. I can go to the debrider, which you can see tissue removed. There's a population that is more powerful one, which is irrigation. So it gives you irrigation. Normally, I will check the local anesthesia in the terminus or saline inside the terminus, so this can work better. Except it has its own irrigation, which would remove more tissue. Night guidelines, there is no difference in alternate surgical plater, but the brighter, surgery, there is no one superior to the other. In our practice, I think that the surgery do a lot of frustration, which is annoying to the patient since they are doing every single surgery 5 minutes. You can have a lot of frustration, especially if you burst a lot on the anterior wall of the terminus or anterior part of the terminus. This one less frustration. I didn't see issues with this one, to be honest. A lot of it. Is that all right? Any questions for it?
Okay, so what we're gonna do is that we can start, I'll say, we'll go that side, so we know who was and then we'll run again. I get the tonsils, but everyone can get the stuff from here. So once put it in, will be set it off. Okay, so what we're gonna do is just gonna try to work on the tissue first.
I'll give it the private. The private تشوف تشوف التاكل ليش برضه بيقلل البتاع انا ما بعتبرش يعني انا عمري يعني انا ايه بقالي 6 سنين مثلا دخلت تربينكتومي باي سعود هذا السيرجري.
You want to set
في حاجه معانا بس it's an indication that is written in the book. We cannot tell the patient not to use it.
And again, so what we need to do is the initial position. It's going to send you the down.
This is
And what is doing?
it's gonna bleed. The heart and bleeding
Relation. Make sure
you tell them why you done it in the clinic. نفس الكلام بتاع الانفكشن.
You start the tissue off. You start to learn and move around.
It's a frequency.
Go around, plate and go on. Down. Okay.
Except if we are doing
Down 1, 2, 3, and get
the hospital, otherwise we get 160 round. We can belong the same bigger treatment in language theater. You will get a thousand and take pounds of dust. يعني بالضبط يعني مش
No, keep it down. Keep it down.
مش ليا للمستشفى دي بتفرق.
Just keep it down. Yes, 3, yeah. In. No, not ablation. Yeah. It's like there is a suction. It's block. Not suction.
The one that's also about. The block, the six line check. Can you get straight from upstairs? Does somebody get us rearranged from upstairs? I don't know, just kind of figure just in the meantime, just really. Somebody could learn she has not sharing, a big problem, big patients,
Yeah, yeah.
Yes. Sometimes it's lots of ten. The. Where's the upstairs? Yeah, upstairs in the clinical stairs, we will find it on the lock one or not. No, no, if you just gonna go the just put it on. Push it 1, 2, 3, that's it. This is the good thing. Thank you. Go there. Finished. Thanks. Yeah. No, please. Okay. Like this. Yeah, but we need to put it a little bit there. And the suction is between the lower. And push it. And make sure that you stop the tissue. Yeah. Patient. Push. This one is you push. This is more funny. You need to yeah, don't leave it. That session is relation. Great. Great. Yes, but more faster, more faster. Yeah, that's time stuff.
Have you done the PowerPoint presentation or but the result you found?
Yeah, I have the.
That's something part of it. Yes, yes, they meet that.
Yeah.
You sent it to me. I have a look at it and then I have a good idea to discuss with the author.
All that thing, right?
Yeah.
I do it.
No, in the calculation, you get there, and come to see one person, that's it. See like that. We don't want to then, we need to go ugly, and we don't want to do a hole like this. We need to change the color of the set. You see, one game, still black and actually. You want to do almost like this, but playing for that part, but that's anyway. Answer clear.
What's the switch is not change this.
So how long the contract and
Same like this.
But it's very slow.
Anyway, we're gonna do it on the tonsils, okay, so do like half of the tonsil like a tonsil, okay, so we're gonna overrun it, so don't worry. Faster so you can get a time and like go in and go out so you can suction it out. When the suction is there, it's subdivision with you, and you get a time.
it's up the time here.
1, 2, 3. No, coagulation, yeah, you push on the point
Yeah, that's enough, 3 minutes enough. We don't want to make a hole. Change. This is good relation. This is a hole or more. This is the hole we believe in. From behind, from the here that if you do like this, yeah. From this. Go to the back, we finish that. We'll get start with the constant now. Yeah. Push it on the, it's like a bleeding ball, once I get pull beforehand. I put on the bleeding ball, yeah, push it once, yeah. Now we get the tonsils. For the tonsils, the same, like, same idea, but from here, this is just to push the pillar to the inferior pillar. Once it's come on. They're asking if we're gonna like, so it's retract the phones with me, is it, saying, we're not gonna retract, so you just let the. Yep. Yep. Thank for the animal. Make it more care. we get like a mirror. Yeah, and just try to the
مفيش حد ما بيشتغلش مفيش حد
it's with the mirror. Can I see it from that side? Yes. Can I use to do it? This. In my opinion, but if we need to make it more curved, but if we make it more curved now, we may be able to. Once we use it. Much, not much. Okay. Yeah. That's fine. Don't get into more. Like we really. Don't get into that board and it's the muscle and stuff. Next. Sorry. Yeah. Is. Yeah, like where you went. So literally it was like. You might know which one. It is. I see these are
Yeah.
Do you have any? It's just allocated. Yeah, basically they asked for the with their helping impression. So then they, because I was in touch with them, they have given their now it's wrong. And now it worked correctly. How many new ST3s on the wow, and how many so then it's like because when I applied, it was a very good case to know how much still after the looking at the old and the other way, the first season the show. Then you have to begin to oh, so you can't step. I mean, yeah, it's good. Yeah, it's going to have started in. That was fun. When you rank like some, they didn't rank like team as well. Yeah, primary. For example, I know like my friend with the team also. That's very much. But we went to make the way out. Then you know that right? Yeah. That's how you manage. But later on, for example, they didn't it was a bit of granulation. I think took a bit of granulation. Just, and I didn't want to like so I wanted to just sort of guide it nice in my easy problem. So I think so. I wanted to say Mark has got yeah, he just makes the question why I was like, it was primary there. It's all there. Like treatment and stuff, but it's just very. And those questions, which one didn't like it doesn't look like long line piece of on it. I didn't know if it was the side. That would be random. So I basically say yeah, right. Yeah. Then I think maybe it's not even being treated, but then they say it's very much funny that unless mentoring now, I think it may have been yes. I certainly think that the for this giant said that he's no, the bigger problem. So if you go by
I was negative.
I think that.
Yeah, no, I mean,
So the other thing, that's what
people visit, by the time I came, he was kind of resigned to it. And then I just take just and the reason why, I prefer general as well. Really? Yeah. Just don't remember I used to have been by then. So that then sort of. But yeah, it wasn't easy again. Just okay, so you've been working on it.
Yeah.
Did you spray a job? Yeah, absolutely. That in loads of spray. And I heard so then wait. Yeah. Ideally, overall big change. Someone like me, even you don't know spray, but when we do, we just I didn't straight in. Yeah, well, it's fun to get. When you decide to do it, you give it some more time. I don't have any. It seems like last year, the same time. It's not an assessment. I was like, oh, no, we're not going to do everything is one. Keep the time in mind, such a hurry. It's never a dull day. Based on these fingers. Without updating. But I guess they're full of these. Then I work on. I think there was a yeah. Yeah. No.
I consulted. No.
I know.
So they actually this year as well, they refuse to give you marks in the newspaper.
High volume.
There was 6 big.
The last presentation.
Nice. No hanging around.
They say the first one yeah,
Someone must have got that.
yes.
Yeah, probably not safe.
Yeah, but I know that's
Yeah.
and then
One.
Yeah, they've gone for it.
like when 71 someone else right, go back to stuff.
I just needed.
I believe there must be
Sure, it's in Doncaster.
and then after a month, depending
You know where you can print the form yet, or we've got to.
Training in the nerve. I do want to go into this too much there. But we are better than that. Yeah, but usually they've got this thing this year. Experience.
I just.
Probably go down to like 3 or 4.
Then I can take it to. So they'll have to take.
Maybe. But no, it's no more problems. It's not bad thing, but I think. Because I had to get dropped in the I think I'm bringing up. Come around. They never update to the I need to Yes, see. I don't have at night. Yeah, and then yeah,
Maybe that's better. Because if you have to do it to it, traffic back.
And if all the people that might not even think about applying, you know, like, oh, there's no job here, or something commission. Like, you got a job.
Yeah.
And that's and a lot of people think you're going to do like you say, but you do
you remember when
that's what no, I didn't really feel like I'm trying to figure it. I declined. And it's still possible for some of the That's great.
Oh, yeah.
Make sure my mistakes. You like to go my I'm in is you got it. Yeah, I think I'm supposed to I'm in It's good that it started like the game in there. Even if you done the different second actually, you still so obviously, for example, the time will be or whatever. Yeah, I think you said it's good. Yeah, I probably will do when it comes to yeah, I can do picture since we need I recommend you.
a ratio of
emails to responses is 5 to 1.
On holidays, bring anything, I just like buy them.
But really, we're not evidence, it's always really ready. This is what you need. Like NHS induction. Yeah. That's the strong. It's the most expensive. This is not unusual, even for UK trainers. Yeah. I mean, I did it.
July.
Oh, July.
No, October. Yeah, July is when.
But exactly. Okay. Yeah, you'll never see one.
No,
Yes. I think that's what we did. Is I remember point which have you driving. I did. I had it actually. I had a really easy answer. I tried in shorter days.
It's
not like you're reading. Yeah, yeah. So maybe, yeah, you know, if it was a lighter day, or if there was, I think one time I had no days. Yeah, study of research. And so, you know, say, what dates do you do? Like, one big private engineer. 4th of, I think 3rd of March, we don't know. But last day, like.
Yeah, but yeah, to make sure that.
So regardless, even if it's not, he actually.
Like, because.
Still, yeah, still, and then you know that. What you're lacking, and then you. And the hammer, I then that.
Take this off. This one off. Give it, so this one doesn't need the suction. Usually we're gonna put the suction just near to just the same, just because we're gonna burn a little bit. So sorry for this, we need somebody to catch it for him. So one can have that. And then the same way, awkward. Yeah.
Was it on 4?
Yes, you want to put more. Let's now put it on 6.
4 and see what. I think it's more on the positive.
So what we can do, we can push this. There is plenty of space on the bed.
One second. That's
Haven't tried, I know that you're not doing any more surgery, that's it. Shit for you.
I'll bet that in second. That's here again. Already when you enter the ablation.
It's nice, fancy, but we do the larynx, we have the larynx, we have. Answer. The scan, I think the machine is something. Normally, this was mentioned that but the team will arrange their trains. So Mr. Senadi, you know, like this one, I do not play but he's in most of the so he looks really, he's been below that. So it's the best. So he's really, divided with me.
Nothing about the plan, I'm doing all of the, what that is, this, that, really, but I didn't have the opportunity. I'm still working one day in one use. You're telling me. Yeah, especially if the machine is going to the bank. Yes, it's right past the. That's all it's going to final. This is the training things people get in this.
Calculation is back.
I'm going to try to set that out.
They train at the time.
Yeah, that's what you do. And you get to join us. That's big.
Yeah. It depends about how it is about the yes, I'm the OCD, so we normally do another later as the bride. The only thing I would say if you're very for the bride, and wait for 5 minutes and try to do something a bit earlier than that. But once the message will increase the blood pressure, it may lead to the bride. With this, the bleeding is much less chance. But with the bridle, to be honest, more than that, I can see the tissue is removed under the vehicle and I read my bridle. Here, you need multiple effort until you see the tissue is removed. You have a better another, you put saline, normally I will inject the third, and then the more you have saline, you have to use the side, the more you work better to decrease. At least they have another one which have an irrigation. We give you saline and
Yeah, intracapsular.
then second is try to go to the surface more so you can see yeah, don't make the see. So you can see one, so you can see the subject. It's very big. This is very, very big amount of tissue. It's very different from the first time you can see the reduction of the not satisfactory, but as I said, that the bridle is more satisfactory. Different way, my colleague different. So he through labor and he agreed and goes to the posterior part to remove. Removes the whole tissue and removes the whole. And which is the dorsal filtrectomy, dorsal coblator. I do the bridle. I have the bridle go up to the end. It keeps moving up to the bone, and then you can see
Huh?
Not before, just all this subject from the mucosa to the from lateral to medial. Or medial, sorry, medial to lateral. Medial to you can use it as a sub, as a diasurgery. So if you went with the operation only and then the cervix, you are doing diasurgery. My issue is that diasurgery, doing this with this one. First of all, maybe I'm a little bit different. What is the indication to do a turbinectomy only, or turbinate surgery? So the indication is not a lot, I will say, but mainly allergic rhinitis, not responsive to medical treatment. You could discuss with him no treatment, medical surgery. He's happy that he's willing to go for a surgery if you are not doing a septum, but doing only a turbinate surgery. In which can repeat in 3 to 6 months, except if you are removing the turbinate doing partial turbinectomy. So if we are talking about the bride ablation, in 3 to 6 months, turbinates can become big inside. So you need to be careful how you phrase it to your patient. At the end, it's a patient's choice. You want the surgery to decrease, you don't want the medication. Outside, you don't 15 years old, you don't put the spray on a regular basis. You want something to decrease for the medication to work. So you need to be careful with the medication. On normality, that on the turbinates we do outfraction. Yeah, it's coming up. Right, so outfraction is a must. And I do it in all my rhinoplasty, by the way. In all my rhinoplasty, I do an outfraction of the field. It helps when you are doing the set. This is the other way of thinking, because yes, it's a very nice tool. It's a very good surgery. It's a 5-minute surgery. But you need to be very careful with the application of the patient. Yeah, you need to be very careful. Right, this is not a long-lasting surgery. All of them, except if you are removing the mucosa from the turbinate forever. Right, but all of this in a few months, the allergies and mucosa will become big again. Because a lot of patients will come to you in 6 months. Doctor, I can see the same. Did you do the surgery or not yet? I've done this very much. We have discussed this before.
Is there a risk of harm? Yeah. The shares have now. I don't know. I see my full
The literature is the same, to be honest.
So
there isn't much, it's the same. It's just it's really the ones change, which is.
Who is doing that surgery, just to remind you again. So normally what will happen, these anterior parts of the they can be careful with drilling a lot of the anterior parts of the station. This elevation will see, if it happens for a long time, it will annoy him. Right, this can cause adhesion. Be careful anterior part. Posteriorly, unlikely to crush, likely to have adhesion, but it can be more serious. This is the branch of the artery. Don't be like it's right as the virus has like a dissection. You dissect them, So you don't burn at all.
Whereas
It's less frustration, but
it's like a hangman, it's like a round circle.
because they can be around, they can see one. So, yeah, when you do the answers, decrease the pulsation, coagulation in the beginning, because this will cross. Procession is much better طبعا than the last.
It's better at blades.
You know, to enter to the so I have a process going on.
Laryngeal is
The ENT
mentioned.
Over the head surgery for
all like.
It's 5 now.
Can go up.
Simple wireless tray.
أو يعالج البرسنت بتاعت أنا خليت لي واحد
والله احنا نشتغل في الموضوع ده.
كده هو نزل دلوقتي السماء
Many people really